So one thing I wanted to ask was about collaborative care models in healthcare, really. So we're hearing a lot about this in primary care, and most often I think we think about mental health care specialists going into a primary care setting as perhaps a specialist to offer some collaborative care and management of patients. It seems that this might be right for addiction treatment as well, and I'm wondering if we can speak to what that might look like, or what a collaborative care model for addiction treatment might look like, and if some of us are already doing that.
So spending time in an outpatient opioid treatment program, it's interesting, having been there for about a decade and watching the way the system works. It's 100% collaborative. There isn't a single day I could function in my job without all the professions, many of the professions that we've talked about today. So social worker sort of doing the intake process and helping devise treatment planning and counseling around that. Providers, both advanced practice, nurse practitioners and PAs or MDs who can, carry out the treatment plan for the patient, provide on-site primary care and or psychiatric care for the patients, nurses who can dispense medications, and pharmacists who can work with us to really look at medication interactions and things like that. So I think that that's a microcosm that we could really look at from a collaborative care model for addiction treatment that I think has worked well for many, many years, and think about how that can be adapted to other settings.
And Jeanette, I'm going to press a little bit further, because I know one of your passions is really interprofessional education. Mm-hmm. And if we think about addiction treatment as being collaborative, why would you say it's important that perhaps we learn in collaborative settings?
I mean, I think you've already heard about today that many of us do very similar things in different settings. And if we're not on the same page with how we screen, assess, and diagnose, not only is it confusing for the healthcare system, it's confusing for patients who access many different ports of the healthcare system, if things are being done differently or they're hearing different messages. And because I think addiction does, as we've already talked about, span so many different professions and settings, and patients who are not even accessing care at all, as Robert's mentioned a couple times, we need all boots on the ground ready to manage this disease. And so I think if we start from a foundational educational level and we're all on the same page and contributing, because I think the most important thing is that although we may look at the problem in similar ways, we all have unique training backgrounds behind us, and that can really add so much richness to an educational platform.
Yeah, let me add that over the course of the treatment of addiction, of the history of it, treatment has been pushed to the periphery and into places that are not connected to other forms of medical care. And that with the collaborative models, it allows us to reintegrate this treatment into a setting where it's actually going to be effective, instead of being pushed to the periphery where it's had less effectiveness than it could have had.
Do you mind expounding on that a little bit more? Maybe give us an example, Robert.
Yeah, I mean, the traditional establishment of methadone clinics in the 1970s really made them standalone drug treatment centers without connections to dealing with the other problems that people with opiate addiction have. For many of these people, opiate addiction is not their primary medical problem. It's a secondary problem that's occurred because of underlying untreated mental health problems, childhood trauma, PTSD, all of these things that lead them to try drugs, have them drugs seem effective in the short run, and in the long run lead to addiction. And if you push the treatment for the addiction to the periphery, where you're only treating the addiction, you're not going to treat the underlying problems. And without this collaboration with other people who can help you deal with these other problems, the treatment for addiction is going to be less effective than it should be.
Thank you very much. Jeanette, I'm going to push it back to you, because you work in an opiate treatment program that actually incorporates primary care. Can you speak to that?
Yeah, I mean, I think it really shows an example of sort of integrating addiction treatment with traditional medical models of how we conceptualize healthcare, and integrating those together, I think, has been really effective, not only for bringing patients in and allowing them to access care that they might not have otherwise, but it gets at this. How do I put it? There's a lot of mutual mistrust, I think, that's perpetuated in traditional healthcare settings in dealing with patients with substance use disorder. So patients may have had negative interactions with healthcare systems in the past, and healthcare providers may have had negative interactions with patients with substance use disorder in the past. And there's this black box of what treatment looks like, kind of similar to what Robert was talking about in these peripheral treatment programs, that no one's on the same page. And I think by integrating addiction treatment with medical care, we can sort of start to break down those barriers and really push away that mutual mistrust and, quite frankly, work at changing the culture and destigmatizing the disease.
That was my thought as you were talking about this, that even at the before treatment centers were open, I mean, this was something that was thought of as sort of willpower, moral failing, criminal, very criminalized, and sort of sent to, not to a treatment center, but sent to prison, jail. And that bringing it into a treatment center where it's alongside all other medical illnesses provides the opportunity to really see it as a disease and helps to destigmatize it.
One model that's slightly different than the model I think that you were mentioning. For about 5 years, I worked for a primary care doctor in his office, and I would go in one day a week to see his patients who had dual diagnosis or patients he was putting on Suboxone, and he didn't even have the time or the ability to do individual psychotherapy with them or group therapy. So I would provide those services in his office for them, in a primary care office. Yeah.
Thank you for that.
I just want to, this is a little bit different from what everyone else was saying, but I just wanted to go back to something that Jeanette originally said, and I think it's the awareness. So I've been, had the fortunate ability to collaborate with Jeanette on some of these interprofessional educational programs that she's developed, excuse me, and I think PAs are, trained as generalists, and I think that, other professions go down very specific training paths, but sometimes you forget to ask. Like, it's the awareness that in an OBGYN setting or in an endocrinology office setting for a PA, you still need to ask. It's the awareness that it's just a simple question you can ask. It's a simple screening. And in that, you can collaborate with others in your practice and collaborate with freestanding primary care clinics associated with, addiction treatment and other things. So it's just that awareness, and that program that she developed was incredible, and I think it just made all first-year PA nursing and medical students at our institution aware of the ability and gave them the tools to ask.
That's great. There's no wrong door. Patients show up everywhere.
Right.
So we need to have the skills to meet that
Yes.
need.